Ladies and gentlemen, before we proceed to our final point of destination, which is PACU, allow us to show and guide you through the entire perioperative experience of the patient, and let us give you a glimpse of how the OR staff play their respective roles the NMMC way under the stewardship of our dynamic supervisor, Mrs. Lorna P. Paduganan. A day prior to the scheduled operation, once the next day elective cases are already posted by the anesthesiologist, the OR supervisor, along with the head nurses, will make pre-operative plans. They aim to allocate 2 staff nurses to stand as scrub and circulating nurse for each of the 7 operating beds in a normal elective day in full swing. 1 ER/OR bed for ENT cases, 1 OB/OR bed for OB/GYN cases, 1 white room bed for family planning cases, 1 pink room bed for emergency cases, 1 green room for ortho cases, and 2 blue room or main OR tables for general surgery cases. Most of the time, the head nurses extend beyond 3 o'clock to make pre-operative rounds to see how prepared the patients are for their scheduled operation the next day. On the actual day of the scheduled operation, the operating room outside wardman will fetch the patients in the ward. Then the ward nurse on duty will escort the patient to the OR and makes nurse-to-nurse endorsement with the circulating nurse. While the circulating nurse is conducting assessment interview and double-checking the pre-op checklist of the patient, her partner scrub nurse is at the same time preparing the operating table, gathering materials and instruments needed for the operation. Inside wardman will then transfer the patient to the operating bed. At this point, the anesthesiologist will take over in directly attending to the patient. The patient will be hooked to monitors and be prepared for anesthesia induction, be it general, regional, local anesthesia, or IV sedation. While the circulating nurse is assisting the anesthesiologist, the scrub nurse does the surgical scrubbing, then serves the surgeons in donning gowns, gloves, and draping.
Then, this is the final moment, when the patient now floats into unconsciousness, putting his life in the hands of the operating team.
Listen as the crowd would sing. Now the old king is dead, long live the king. 1 minute I held the key. Next the walls were closed on me, and I discovered that my castle stand upon pillars of salt and pillars of sand. I hear Jerusalem bells are ringing, Roman cavalry choirs.
After the operation or special procedure performed on the patient, this is the time when the PACU nurse will begin to come into play, taking the center stage in this part of the patient's OR life drama. The PACU nurse usually is the first person that meets the patient's eyes when the patient comes back into consciousness.
Now, ladies and gentlemen, we have just landed to the port of Post-Anesthesia Care Unit. Now sit back and relax as we guide you to the PACU virtual tour and lecture.
Can't wait to get home. Baby, dial your number. Can you pick up the phone? 'Cause I want.
Welcome to the Post-Anesthesia Care Unit, referred to by most as PACU. It is the area of our hospital within the operating room complex designated for recovering from the immediate effects of anesthesia before either going home or on to another in-hospital destination or receiving floors. In our institution, we have 2 post-anesthesia care units, OB PACU, which has 2 bed capacity, and the main OR PACU, which has 6 bed capacity. 1 staff nurse is assigned in each unit.
Oh, since my first heated love affair.
No matter how simple or how complex a procedure, the main focus during the recovery room period, simply put, is that all patients awaken safely and comfortably. The priorities are for the postoperative patient's safety and comfort. After an uneventful operation or special procedure performed on patients, he or she will then be transferred from the operating bed to the PACU stretcher using an easy move transfer board, already made to assume postoperative position, specifically ordered depending on the type of operation, the site of operation, and the anesthesia used. Most common positions to assume are for post-craniectomy, moderate high back rest to lower intracranial pressure. For post-hip replacements, legs are maintained in an abducted position to prevent hip displacement. For post-palatoplasty or tonsillectomy and other operations under general anesthesia, especially on young children, SIMS, left side lying or prone position to prevent aspiration of blood and oral secretions. For post-operations under spinal anesthesia, patients are maintained on flattened bed or supine position for 6 to 8 hours to prevent spinal headache, nausea, and vomiting. Then ideally, escorted by the surgeon, anesthesiologist, and circulating nurse, the patient will be properly endorsed to PACU in OD.
Okay, ready for transport?
However, another scenario is, if the patient is under general anesthesia, it is a fact that he or she often requires a breathing tube, which we refer to as an endotracheal tube. This is an artificial airway, which in most cases will be removed prior to full awakening, either at the end of your surgery or shortly after arriving in the PACU. But if the condition of the patient demands that immediate post-op extubation is not yet possible, the circulating nurse will coordinate with the PACU nurse to prepare either TPs or, in extreme cases, set up the mechanical ventilator and other necessary equipment for carrying a patient in critical condition, such as suction machines, patient monitor, cardiac monitor, infusion pump, and the e-cart. For infant post-operative patients, the PACU nurse will be informed ahead to put off the air conditioning unit and pre-warm the receiving bed. Then, once the post-anesthesia care unit is ready, the intubated critical patient will then be rushed to the PACU on ambu bagging.